مساء الخير. احنا هنبتدي دلوقتي السيشن بتاعت البودي ايميجينج. الشير بيرسونز الاستاذ الدكتور سحر الجعفري، الاستاذ كليه طب جامعه عين شمس، وانا الدكتور احمد منيب. في انتظار الباقي الحقيقه، لكن علشان الوقت احنا نبتدي فورا. الفيرست presentation by Assistant Professor Dr. Rasha Salah, Radiological Imaging in Pancreatic Cancer Assessment. اتفضلي دكتور رشا.
Good afternoon. It's my pleasure to be here again with you. Today we are going to discuss radiological imaging in pancreatic cancer. This is our outline. We will discuss the CT and MRI pancreatic protocol and evaluate the detection of the pancreatic ductal adenocarcinoma, and also we will give hint about the assessment of resectability of the pancreatic ductal adenocarcinoma. First, let's talk about the pancreatic protocol, either by CT and MRI. To image the pancreas, a dedicated protocol must be implemented during imaging the patient. First, for the CT, it's not a routine triphasic CT. We should implement what is called the pancreatic phase, which is about 35 to 40 seconds from the contrast injection. Why this phase is critical? Because as we can see over here in the middle image, this is the pancreatic phase. Here, the pancreas shows maximum enhancement of its parenchyma because the pancreas is a glandular tissue, so it shows intense enhancement. But this enhancement appears only in this pancreatic phase. While if we inject the tracer and image the patient earlier than this phase, as we can see here in this image, then the pancreas appear to be not enhancing enough to evaluate pancreatic lesions. And on the late images, the pancreas shows wash out of the contrast, and so we can't again evaluate the pancreatic lesions. So the money image for evaluation of the pancreas is this pancreatic phase. As regards the MRI, we do first the non-contrast MRI, and against the routine, the known that pathological lesions are best demonstrated on T2 weighted image, pancreatic lesions are best demonstrated on the pre-contrast T1 fat suppressed image. As we can see here, why is that? Because the pancreas normally shows a high signal on this image against the background. So any pathology can be very well visualized in this phase, like as if we are injecting contrast material. And then we perform the same pancreatic protocol similar to the CT with the pancreatic phase in 35 to 40 seconds from injection, and then the portovenous phase and the delayed images. And of course, as we know, the pancreas is a glandular tissue, so it has some exocrine and endocrine function. The exocrine function mandates the evaluation of the pancreatic duct, so we do as well MRCP images to evaluate the duct system, which is a very important part in evaluation of the pancreas. Next, we will speak about the detection of pancreatic adenocarcinoma. Our role of imaging, first to ask, is this a tumor? This is the question to be answered, if yes or no. If it is a tumor, then we are obliged to implement the location of this tumor for the surgeon, and also to identify its staging to allow the proper evaluation for treatment plan. So to ask for the evaluation of the pancreatic tumor, the clinician should ask for CT or MRI. Which imaging modality is better for evaluation of the pancreas? As all we know that CT is the cornerstone for evaluation of pancreatic pathology, especially for solid masses. If we have suspicious that we have a solid pancreatic mass, then CT will be the first line to investigate the patient, and it could be satisfactory and give the full evaluation. But MRI is reserved only as a problem-solving technique, and also for evaluation of small masses, and if there is a high risk for hepatic focal lesions. Also, if we are dealing with a pancreatic cystic lesion, then we ask for MRI, not for CT. Let's see the value of imaging and evaluation as we can see in this case. This patient has 59 years old and presented with pain for a few days at the epigastrium. her labs demonstrated that she had elevated amylase and lipase. Of course, this is a clinical scenario to suspect a case of pancreatitis. The patient was referred for CT. This was her CT triphasic study. This is the early arterial phase. This is the pancreatic phase. And these are the portovenous and delayed images. These images were reported as a case of pancreatitis, necrotizing pancreatitis with peripancreatic necrosis. Do you agree with this assessment? Unfortunately, the patient received the treatment for pancreatitis, but the symptoms didn't properly resolve it, so the patient was referred again for evaluation by MRI. This was her T2 weighted image. We can see heterogeneous lesion at the pancreatic body. And this is the pancreatic phase showing hypoenhancement of the lesion, which shows delayed enhancement on the subsequent image with significant irregularity around and encasement of the vessels seen. So this appearance is not of a chronic pancreatitis or necrotizing pancreatitis. This is suspicious for having pancreatic adenocarcinoma. So this can explain why the patient didn't have relieving symptoms in spite of the proper hospitalization and treatment. When we take a closer look for this patient, we can also notice that there are multiple peritoneal nodules located at the omentum and also multiple mesenteric nodules. When we return back to the CT, are these findings were there and missed in the CT? Actually, some of the nodules were well visualized, as we can see here. This is a small nodule over here, and there are some nodules at the omentum around the transverse colon. And unfortunately, they were missed on the initial assessment. And this is another paracolic nodule at the paracolic gutter bilaterally. When we evaluate the liver, there is a small focal lesion located at the left lobe, which is well demonstrated on the DWI. So this patient has also metastatic disease to the liver, not only for the peritoneum. And it appears as a hypoenhancing lesion on the dynamic study. While when we look back in the CT, it was very hard to appreciate this hepatic focal lesion. So we look again for the pelvis to see what is this structure, and it appears as an enlarged left ovary. Remember, the patient was 59 years. Is this accepted for this age group to have this sizable ovary? No, this is a suspicious ovary on the CT, but it wasn't reported as well. When we return to the MRI, this ovary appeared to be enlarged and heterogeneous, and this is a Krukenberg tumor. So our final diagnosis was pancreatic body adenocarcinoma with peritoneal deposits, left Krukenberg tumor, and metastatic hepatic focal lesion. So the proper evaluation and assessment of the pancreatic tumor can help in proper evaluation of the patients. Let's see how we assess the pancreatic tumors by assessing their resectability, which is the cornerstone in staging of pancreatic cancer. According to the American Joint Committee on Cancer, the pancreatic cancer is staged as stage 1 and 2, where it is resectable tumor and can be surgically removed. While stage 4, which has a distant metastasis, it is also called unresectable tumor. And there is a borderline tumors in between both categories, which is the stage 3 tumors, where there are involvement of the major vessels. And these could be unresectable tumors when the surgery can't be operated due to suspicious that can be injured the surrounding vessels. However, some of these tumors can be borderline resectable to shrink down after receiving chemotherapy, and then the patient return back to resectability. Let's see how we can evaluate these tumors into the radiological imaging. First, this is the cornerstone in our reports, that we assess the morphological appearance of the tumor, location of the tumor, the size of the tumor. This is very easy and all of us can do. The next step is the proper evaluation of the vascular relation of the tumor. The important vessels around the pancreas include celiac trunk, SMA, SMV, and portal vein, and also the hepatic artery. These arteries should be implemented separately in the report, and the proper evaluation of these vessels should be applied during the reporting system. And also evaluation of the other abdominal lesions, either peritoneal or hepatic metastasis. This is how we report the pancreatic tumors. Let's see how to do this evaluation. Some nomenclature should be identified. First, for the arterial assessment, we should evaluate the artery as a cross-sectional imaging, as we can see on the CT. This is the artery. We plot an imaginary line in the artery to divide the artery into two halves, to divide this part as 180-degree circumference of the artery and the other half at 180-degree circumference. And then we evaluate this relation to the artery to the tumor, to evaluate if the contact of the tumor to the artery less than 180-degree of its circumference, or it is more than this contact. If it is less than 180-degree, then this is called abutment, and this patient could have a surgical excision of the tumor, and these are resectable tumors. Again, to identify the other tumors where there is more abutment by more than 180-degree, where the artery is completely encased by the mass, this is called encasement, and it is more than 180-degree. Also, if there is distortion of the artery or irregularity, this is another sign that this is an irresectable tumor. Regarding the vein, we do the same for the vein. We plot this imaginary line and evaluate the contact of the tumor to the vein. If it is less than 180-degree, then this is abutment. If it is more than 180-degree, then this is encasement. If there is distortion or teardrop sign, then these are signs for irresectability due to tumoral infiltration. Another classification system is performed particularly for the portal vein evaluation to allow the evaluation of the contact of the tumor to the portal vein, either the contact from one side or from both sides, and the length of the contact, if the tumor is encasing the vein or not. This is very important for the portal vein. Let's see some examples for these lesions. First, let's see, this is the vessel and this is the tumor. The contact surface here is less than 180-degree, so we are dealing with a resectable tumor. Let's evaluate this tumor and relation to the SMV. There is a hair-like pancreatic tissue separating the vein from the tumor. So this is a resectable tumor because it is completely separable from the mass. Again, this is a huge mass from the first side. This could be potentially a resectable one, but when we have a closer look to the contact between the vein and the mass, we can see that there is a spurred pancreatic tissue, normal tissue between the mass and the SMV, and in spite of the large size of the mass, this is a good resectable tumor. Another example, this is the superior mesenteric artery, which appear to be encased by the mass by more than 180-degree of its circumference. Regardless the site of the encasement, or either from posterior, medial, or lateral surface of the artery, we evaluate the contact surface to the tumor is more than or less than 180-degree. This is the vein which is not in contact with the tumor, and there is complete clear fat plane between the vein and the tumor. But making the artery is completely encased with the tumor make the surgery more difficult to be performed. So the arterial involvement is more important than the venous involvement regarding the surgical plan. This is another example of a tumor that is seen truly infiltrating the superior mesenteric vein with the tumoral thrombus protruding into the vein lumen. And this is, of course, a resectable tumor. So signs of resectability is that no SMV or portal vein distortion, as we can see here, while regarding the arterial system, there is a clear fat plane around the celiac trunk, hepatic artery, and SMA. This is an example for MRI, how we evaluate the same as the CT. This is the mass, and it appeared to be completely separable from the SMA and SMV. And this is the dynamic study. Let's move to the borderline resectable tumor, where the SMV and portal vein appear to be distorted, narrowed, or occluded, yet it could be reconstructible. We, as a radiologist, don't imply to the clinician that this is a resectable or not resectable. We just report what we are seeing, and the clinician have the choice to evaluate is this patient can do a surgery or not because of the potentials of the availability of the surgical theater the operating team, and the availability of grafts for evaluation of the encasement of the vessels. So the surgeon is the one who decides, is this resectable or not? So if we can see this mass is in contact with the SMV and it appears to be distorted. So this is a borderline resectable tumor that is preferred to have neoadjuvant therapy first and then return back for surgery after downsstaging of the tumor. This is another example for borderline resectable tumor with contact to the SMV and the abutment of the SMA. Again, the unresectable tumor, as we mentioned earlier, the encasement of the SMA or encasement of the celiac trunk more than 180 degrees with complete encasement around the artery. As regards the body tumor, there is an encasement of the celiac trunk or unreconstructable SMV and portal vein junction. Also, this patient has distant hepatic metastasis, and so this makes the patient to have unresectable tumor. 1 minute. Another important sign for unresectable tumor is its contact with the abdominal aorta. We forget to look for the abdominal aorta. So if we find the tumor having a posterior extension to the abdominal aorta, this is of course irresectable tumor because it can't be reconstructed. To discriminate between ductal carcinoma and the neuroendocrinal tumor, the pattern of enhancement is completely different, so we are obliged to discriminate between both entities. Neuroendocrinal tumor or NEAT, they are a hyper-enhancing tumor. This is example for how NEAT looks like in the CT image. We can see a hyper-enhancing mass at the pancreatic head, and this is still hyper-enhancing, and when we form the dotatate PET study, it appeared to be significantly avid. This is how it looks like in MRI as a hypo-enhancing against the background of high signal in the pre-contrast image with hyper-enhancement after the contrast study. And also the metastasis and the lymphoma could be presented in the pancreas, as we can see here that this patient has small pancreatic lesion over here with bilateral adrenal masses and another small nodule at the pancreatic tail. So the multiplicity of the lesion raised the possibility of either metastasis or lymphoma, although they are not so common, but we implement a lot of cases that have metastasis in the pancreas. And this patient had also sizable pulmonary mass, and it was proved to be bronchogenic cancer, and this is the metastatic mediastinal lymph nodes, and this is the PET image for this patient having proving that this is a bronchogenic cancer metastasizing to the pancreas. So to sum up, at the end we need to have a multidisciplinary team assessment to evaluate what the clinician needs in our reports, to implement it in our reports so it improves the patient's outcome. Thank you.
Thank you, Dr. Rasha, for the presentation. Shall we go to the next speaker, Dr. Alia